My slide is visible. Am I audible now, Dr. John?
Yeah, we can see your slides. Yeah.
Okay. Let me just when we are discussing about the drug-coated balloon, obviously we have got the concept of metal-free PCI, or the latest terminology, maybe leave behind nothing. But to improve the outcomes of this drug-coated balloon, since when it was introduced in 2006 by Bruno Scheller, we have been on the verge of attempting to improve the outcomes in various subset of patients. We have got data on ISR, plenty of data, and even the ESC has approved as a class 1 recommendation, and trials are there. We are so comfortable with the ISR. But whatever we said, having said that, in terms of de novo lesion, we are still in the primitive, or I can say we have an evolving data only. Because when you are asked to do a drug-coated balloon in a proximal LAD or a left main, guy can, like Dr. Colombo, can demonstrate, but for a real-world practice, we have our skepticism and reservations. So, having said that, whatever the indications and the evolving indications, if you want to improvise the outcomes of the drug-coated balloon, it is not only the drug that matters, because the drug alone cannot do. Obviously, the recent studies have analyzed, the retrospective analysis of the recent studies showed that whatever the failures in the early generation drug-coated balloon is not due to the drug per se, it is mainly to the lesion preparation. So I want to emphasize the lesion preparation is the main important determinant of all these drug-coated balloons. So we have to relearn how to do an angioplasty before going to the drug-coated balloon. So there are two drugs, everyone knows about that, and clinical data on RCT and a lot of registries and real-world registries. And let us just delve into the mechanism of these two drugs. You all know that, but still I want to refresh it. The Paclitaxel irreversible binding, that drug is being transferred to the lipid bilayer cell membrane into the intracellular area, where it that binds with the microtubules, inhibits the cell division. So obviously the smooth muscle loss, apoptosis happens. This apoptosis is being histopathologically being measured as a smooth muscle cell loss, as well as the preclinical animal model as muscle to artery ratio. That is what I'm going to talk about now. And this paclitaxel compared to the sirolimus has a strong anti-proliferative action and moderate anti-inflammatory action. That is why when we talk of so much of theory, we need to also look into whether it is really clinically translated into benefits or outcomes. That is what we are still lagging in de novo lesions in a DCB. There are a lot of trials on late human loss, but where is the question of the real comparable data or superior data when compared to DES? That is what we are going to discuss today. So the other important thing of paclitaxel is prolonged tissue retention. Obviously, lipophilicity and the tissue retention property obviously keeps this drug into the vessel wall when compared to the non-target area myocardium. So the cell proliferation is obviously persistently inhibited. And to this kind of data, you all know that starting from BMS ISR, ES ISR, and also the small vessel disease, and there are some imaging data on large arteries also, but we need to, when we are talking about large arteries, I always want to emphasize that we need to do not like apply an old style angioplasty. We need to use the physiology and imaging to guide or to assess the outcome, both acute as well as in the long term. So the preclinical data of these balloons, the two type of balloons along with the sirolimus-coated balloons, has shown that the smooth muscle loss, which is an indicator, is more in terms of paclitaxel-coated balloon when compared to the sirolimus-coated balloon. The obvious explanation is more apoptosis due to the strong anti-proliferative action when compared to the sirolimus. Also, the muscle to artery ratio, that means the non-target tissue to the target tissue, because the sirolimus is the one known to have more, the drug is lost more into the downstream, into the myocardium rather than on the tissue. That's why the muscle to artery ratio, otherwise called as non-target to target tissue ratio, is better in terms of paclitaxel-coated balloon. These are all the preclinical studies by this Hera et al. But This sirolimus-coated balloon, this muscle to artery ratio was really not validated. These two concepts were hypothesis generating, but really not validated in any of the clinical studies. So we just should know about the concept, but still not yet validated. So I am not going to much data, only the recent data in 2023, that was in TCT 2023, these two studies were in fact discussed about much. There are two opposite ends of result. One trial says that CKD plays new as well as the sirolimus-coated balloon by Bruno Scheller has shown that the sirolimus-coated balloon is non-inferior. The explanation is the coating, the kind of coating they have done. So he emphasized the coating also matters apart from the molecule. So that is how it is showing non-inferiority to the Paclitaxel-coated balloon. Whereas if you look at this magic touch, which has been failed to show the superiority, and in the trial, it has shown that the late luminal loss and everything is more. So it has failed to show its superiority compared to the paclitaxel, standard paclitaxel CKD balloon. So basically, when we are having an emerging data, but still we are not yet there to conclude which is the best balloon tip. For all practical purpose, what I understand, what my translation of all this concept into clinical practice is basically, when I do ISR PCI, obviously the vessel is caged. There is no question of further remodeling that. So I always choose either a paclitaxel or a sirolimus. In those days, sirolimus. Now that there are not much data on sirolimus, so paclitaxel. But when you deal with the de novo, especially in a small vessel which has been proven, and compared to we have much data on a small vessel and compared to a large vessel. So in a small vessel, it is better always to go for a paclitaxel-coated balloon because it has a positive remodeling. In fact, the lumen enlargement will be there. In such small vessels, obviously, one can have a better long-term outcome. Let me go to the two of the interesting cases shortly. This is a 66-year-old gentleman with a multimorbid guy. Basically, he has a CKD with an AGFR of 20 to 25. He presented with an antivolume, LV dysfunction, and he has multiple lesions, and he is initially subjected strongly counseled and extensively counseled for bypass surgery, but somehow he was not. And one thing is that the distal LAD was not that much graftable, so the surgeon was also not very much happy about grafting the LAD. So we had a discussion, then we wanted to go for imaging and physiology-guided low contrast PCI. And you can see this is the angio which was done elsewhere, and we have uploaded because when we do a low contrast, we always try to conserve the dye. So we will upload the angios done outside, and you can see there is a lesion in the LAD, the moderate lesion in the osteoproximal LAD, and there is the moderate lesion in the LCX, and there is the diffuse lesion in the distal LAD. The distal LAD is diffusely diseased and RCS. So this gentleman, we then did imaging guidance. We first did a RFR of the OM, which was shown as almost insignificant, and then we went ahead and you can see a little bit of dye as a baseline reference, and then we went ahead for the LAD, and the LAD you see almost shows 0.76, which is significant, and you can see the step up when the LAD, when the RFR was measured in the mid to proximal segment, that it is like almost like a 0.95 something. So it was, so the lesion is mainly in the mid to distal LAD. So we need which was the area which was diffusely diseased, so not suitable for graftability. Then we did a balloon angioplasty. We were starting with a small sized balloon, and we did we could not do a pre-angioplasty IVUS because the disease was also tight. So when we did a 2 millimeter balloon, you can see still the FFR was not achieved. It was 0.8. That where when I looked at the data, literature, there were only 3 studies to my knowledge, which is taken 3 different cutoffs. One study 0.75, the one is 0.8, mostly on the PDPA, that is FFR. We have also measured the PDPA here. You can see that the F4 is 0.78. And after doing a 2.5 millimeter bigger size balloon, then the RF4 was 0.92. And this functional testing rules out two things. One is we didn't have any angiographically significant or a flow limiting dissection because we could not do angio. There is no flow limiting dissection. The second one is, okay, we have prepared the lesion well, we can go ahead and do the application balloon, that is a drug-coated balloon, because the drug-coated balloons are only application balloons, they are not dilatation balloons. Then we applied two balloons from distal to middle AD. You can see 2.5 into 20 and the mid one is 2.5 into 30. The question is again how much we have to overlap. That is also there. If too much of drug, then it will be whether it is synergistic or toxic and future may cause aneurysm, we don't know. But we have been very careful in not overlapping too much about the balloons. And after the drug-coated balloon application, we again did a RFR. You can see the RFR is 0.97, and then the IVUS showed a recent area of the small vessel, which was almost like a 2.5 to 2.25. So then there was a good dissection, and you can see the RF was 0.98 at the which was measured 10 minutes after the angioplasty. We did a final angio just for a reference and the insurance purpose. So the issue is now that the way we need to do the drug-coated balloon is not just doing like the old balloon angioplasty. The outcomes can be improved only when we do a imaging or at least a functional guidance, which can tell you at the end of the procedure you are doing a good job. This is another case. This is a laser-assisted hyperphysia. The history is very long, lengthy. So I just want to go into the short history. Old angial MI, moderate LV dysfunction with symptomatic class 3 symptoms. CF is around 40%. You can see this lady had a long CTO. This is the middle part where the stent was there. So there was a de novo CTO in front of the ISR CTO. So there are two lesions, two CTO lesions we need to tackle, and this was really looking like an ambiguous gap. So though there was some lesions, this was nearly looking like ambiguous. So we wanted to do it with the IVUS guided wiring, and then we wired it, and then we did initially with the XGA and then microcatheter, and then the Gaia was inserted. It was advanced into the stented segment. This was technical. The main reason was under expansion. There was some atherosclerosis also, just for the sake of time. Then we dilated here. We applied some laser energies because the instant restenosis was so fibrotic and it was not yielding to a regular INSI balloon. And we applied some laser energy. The one thing I also learned that we should not do more aggressive balloon dilatation after a laser. It was our initial experience that we got a severe dissection hematoma of the proximal lady where there was some laser energy was used. Then we went ahead and stented it. This is another concept, very novel concept which is emerging these days, that hybrid PCI. If you have a large vessel proximally stent it, and if you have a small diffuse disease, non-graftful disease, then you can go for a DCB. So that is what is called as a hybrid PCI, though we did the hybrid PCI here, and finally the result looks okay, which was again confirmed with this. So in conclusion, obviously, unlike the Coronary aggregate meta-analysis, which has a lot of limitations, which has shown that the Paclitaxel has increased the mortality, the recent data from various meta-analysis shows that it's a safer drug. It can be used in patients, especially in ISR, as well as in some of the subset of lesions like the previous speakers have spoken about in men, like small vessel disease, bifurcation. And also it gives the advantage of uncaging the coronaries. So by uncaging the coronaries, it gives the advantage of avoiding the late and very late events and improving the outcomes. Thank you.
Thank you, Dr. Dhamodaran, for that elegant talk. Do you think imaging is important when you plan for a DEB in a large vessel for a de-novo lesion?
Yeah, absolutely. Because you see, when we do imaging, obviously, two things we are sure. Obviously, we will do a pre-PCI pre-planning. That is a must in any. It's a standard of care in PCI these days, and that is a pre-PCI to assess the diameter, length, and everything, plaque morphology, etc. Because some of the calcific lesions which may not be visible on an angio when we are going and doing a drug-eluting balloon, and if it gets rejected, obviously we have to land up again with the invasive problem. So imaging is a must, and all the more during the procedure or after the procedure itself, so it's better. But my concern is like, when injecting a dye through a OCT may enlarge type C or type D to a abrupt closure. So it is better to use IVUS. This is my suggestion. And most of our cases are CHIP cases. They have CKD failure. So IVUS is a better modality. More than imaging, I want to emphasize the role of FFR and some kind of non-hyperemic ratios. FFR is the must, I can say, because when you are doing limited dye area, the case I have done like ultra low contrast where I didn't want to check frequently with the dye. When the FFR wire is there downstream, the archives, if it shows 0.96, I would literally, after 10 minutes after balloon angioplasty, I have literally ruled out any flow limiting resection because the ischemia is not there. So functional testing is all the more important, and obviously imaging may supplement our research. Thanks.
Thank you, Dr. Dhamodaran. I think we'll move on to the next